I want to extend a very warm welcome to all of you to the Spectrum's annual uh, virtual research forum. Uh, there are about 180 participants who have registered, and I welcome all of you. I'm Satya Rao. I'm a psychiatrist. I'm also the director of Spectrum. I also direct the Spectrum's Personality Disorder and Complex Trauma Research Innovation Center. I'll be your host for the morning session, and later on, my colleague, Professor Gillian Broadbear, will take over and host the session in the afternoon. You'll meet Gillian shortly. We will be uh, uh, live tweeting from Spectrum at the hashtag Spectrum Research. So please join us online if you have any comments or thoughts on the presentations that you would like to share with us. Before I start, thank you for not recording the event, as the presenters have not permitted the participants to record their presentations. However, slides and video recordings of the event will be made available to you at a later time. I begin today by acknowledging the traditional owners of the land on which we meet today. It is the Wurundjeri people of the Kulin Nation for us here at Spectrum in Melbourne. And I pay my respects to their elders, past, present, and emerging. I would like to say a few words before we get started. For those of you who may not be familiar with Spectrum, we are a Victorian statewide public mental health service, a center of clinical excellence that specializes in the treatment of personality disorders and complex trauma. Spectrum provides treatment, education, training, advocacy, and research innovation. We provide treatment for people struggling with complex and severe personality disorder and complex post traumatic stress disorder. We also assist our mental health colleagues across the state of Victoria and more broadly across the country when it comes to complexity, severity, and high risk situations associated with a diagnosis of personality disorder and complex trauma. Our clinical work and the training and education that we provide gives us ongoing insight into the gaps in knowledge and science. We also work closely with our lived experience colleagues who also provide us with feedback as to what are their priorities when it comes to research innovation. These things usually shape our research agenda. Having a research program embedded within a clinical service means that our research findings can be seamlessly translated into treatment, training, and advocacy work, amplifying the impact. In that sense, we are passionate about translating research into practice and shaping our research from the feedback we get during practice and training. We have a very interesting program planned for all of you today. My colleague, Professor Gillian Broadbear, will provide you a brief overview shortly about our spectrum research activities. We'll then have three important presentations, three keynotes, uh, two of them from global experts in the field, speaking from two other countries, United States of America and New Zealand, and one from our own Professor Gillian Broadbear. Interestingly, all three keynotes are about how best we can organize care and treatment for people with personality disorders. A range of spectrums, clinicians, researchers, and collaborating organizations will present a range of cutting edge projects related to borderline personality disorder later in the afternoon. I would like to now introduce a close colleague of mine and the head of research innovation here at Spectrum, Associate Professor Gillian Broadbear, to talk about Spectrum's research program. Gillian holds a PhD in biopsychology from the University of Michigan, and she spent many years working in the substance misuse and mental health fields, conducting preclinical and clinical research. After returning to Australia, fortunate for us, she came back. Gillian took up academic role at Monash University, convening the Bachelor of Behavioral Neuroscience and continuing her psychopharmacology research. She joined Spectrum 9 years ago, and we are fortunate to have her at Spectrum. Gillian is passionate about leading research that can be used for education and advocacy to improve our understanding and resourcing of services to assist everyone whose lives are affected by personality disorder and complex trauma. Gillian is a brilliant researcher. She's very pragmatic and absolutely clinically grounded. Over to you, Gillian.
Thank you so very much, Satya, and welcome to everybody, and a big welcome to people who are coming back for our second research forum, because we had our first last year. I'm just going to take you on a bit of a whirlwind journey of developments in the field more broadly, and also what we've been doing at Spectrum, and just introduce a little bit of our program for today. So I'm just going to share my screen with you, and I hope you can see my slide. And I just wanted to make it clear that although this is an opportunity to bring research to all of you, this is also an invitation to people listening to contact Spectrum as well. If you have research ideas, if you've got collaboration, if there's questions that come up for you in your work or at your service as a result of what you see here today. So very much a two-way conversation, and we're hoping that you will get in touch with us after the event. So I just want to move us forward in the slides. Here we are. So in terms of Spectrum's research program, we do a lot of different research projects. You can see there's quite a list here. Where you've got names in brackets after the topic, this is information that you're going to hear presented today. So we have our clinical evaluation programs. This is the work we actually do at Spectrum is being evaluated. We have audits and epidemiological studies, which will be covered in my talk a little later this morning. We do statewide and national programs that includes clinical training and also sort of more broader sort of education. And we have collaborative multi-site projects. You can see we've got presentations there. Dr. Pari Hadari, we'll hear a report from her this afternoon, looking at the very important transitions to telehealth and how those services were received by both the clinicians who were providing them as well as people who were on the receiving end. We've got psychiatry registrars, and they do their scholarly projects quite often when they're doing their rotation with Spectrum, and we have two of those projects being presented today, which is very exciting. And we're also very fortunate to collaborate with quite a few different universities and co-supervise high degree research students, and 3 of them have kindly agreed to present today. So in terms of personality disorder field more broadly, we've seen here in Victoria funding for implementation of many of the recommendations arising from the Royal Commission into Victoria's mental health system. So this has been a big review of how our mental health system works and does not work, and there's a lot of very fruitful recommendations that are being put into practice here in Victoria at the moment. We also saw the formal implementation of ICD-11. So this is the International Classification of Diseases that's put out by the World Health Organization. And importantly, personality disorder has now formally moved to a more dimensional description. So we're kind of losing all of those subtypes of personality disorder and all of those symptom lists that we see in DSM, moving more towards sort of personality traits and severity of dysfunction. So this is quite a different way of diagnosing and thinking about, and also modifying treatments to actually address maybe slightly different targets in different ways. We also saw the introduction of complex PTSD as a diagnosis. This is the first time it's been formalised, and we know already that our work at Spectrum, probably about 80% of our severely unwell clients also have PTSD or complex PTSD. So this is a big change for us as well, and it's going to be shaping our research program in years to come. Just a quick announcement. Australia will be hosting the Conference for the Peak Personality Disorder Group Society this next year in Sydney. I've got a little thing at the bottom, ISSPD, and if people are interested, it's very close to home and it's really worth going to. So have a think about that. So in terms of our own research highlights, quite a large contingent of people from Spectrum attended the Royal Australian New Zealand College of Psychiatry conference in Sydney early this year. We led 3 symposia and we had a number of standalone presentations as well. So that was a very, very successful conference. So Spectrum had its own annual conference last month, which very topically, you can see from the title, is trying to provide some guidance on diagnosing BPD and or complex PTSD, because there are quite a lot of commonalities, but they are distinct diagnoses that require different treatment. Last year at our forum, we launched our Centre for Personality Disorder and Complex Trauma Research, and this year has seen the establishment of that centre. Progressing key research projects here, of course, and we have 3 pilot studies that have now been expanded into multi-site projects, and one of these is going to be reported today. We have been expanding our research team, thank goodness, and we also have wonderful volunteer researchers and summer scholarship students, 2 of whom are starting today. So don't bother reading this, but this is our publications for this year, and I just want to say some of them are to do with diagnostic complexity. So the first one there, sort of sorting out phenomenology related to hallucination in people who have personality disorder diagnoses. And you see at the bottom there's one looking at autism spectrum disorder and its intersection with borderline personality disorder. We have a paper about sexual diversity in people with BPD, as well as forgotten parts of the community, including older adults in whom personality disorders seem to be overlooked. And we've developed a screening instrument that we're piloting in a larger study in the coming year. So thank you again for registering and for your interest and support, and we hope that whether you're virtual or downstairs in our training room, you will enjoy what you see today. Thank you very much.
Thank you, Gillian, for that short overview of Spectrum's research activities and what's happening here in Melbourne and Australia. I now have the pleasure of inviting our first keynote speaker, Dr. Lois Choi-Kane from Boston, USA. Professor Choi-Kane does not need any introduction. She is a giant in the field of personality disorders. Professor Choi-Kane, her keynote address is, "Can research solve care gaps for borderline personality disorder?" Professor Choi-Kane is the director of Gunderson Personality Disorder Institute, facilitating training and supervision for numerous proven treatments. She has worked nationally and internationally to expand teaching efforts on BPD and its evidence-based treatments, and engages in research to study resources for training clinicians who need direction and patients who need access to informed care. With the mentor, the late John Gunderson, Dr. Choi-Kane developed a training program that all of us are very familiar with, the General Psychiatric Management, and she has been expanding its applications. Our aim as a researcher is to expand the scope and reach of effective interventions for borderline personality disorder as a regular fixture of routine mental health care to allow early intervention and facilitation of recovery before the burdens of illness too greatly diminish the developmental opportunities critical to fostering healthy personality function. We at Spectrum have been very fortunate to have a guide and mentor program. And thank you, Lois, for joining us from all the way from Boston. I know it is still weekend for you, Sunday evening. And over to you, Lois.
Thank you, Satya, and it's a pleasure to be here. I cannot say enough how much I've really treasured my work with Spectrum. It is a group of educated, dedicated, and inspiring clinicians and researchers. And I want to say that I've worked with and seen no other program that has been advancing their integration of what's coming out in the scientific literature with the care they provide on a kind of wide-scale dissemination level. So I want to applaud you all for the work you do. I've been highly impressed with it, and also it's inspired my work in the day-to-day struggles. So I'm going to share my screen. See if I can do this correctly. Okay. Can people see my screen, my slides? Yes. Okay. So my talk today sounds really ambitious. The question I want to address, but certainly not answer, is can research focus more on solving care gaps for borderline personality disorder? Like I said, I've been really educated and inspired by my work consulting with the groups at Spectrum, where there is a broad range of services with outreach to clinicians in the community, as well as specialized services providing ongoing support for the most complex patients. Too often, the research literature focuses on very specific contextual applications of care that's hard to disseminate in a scalable way. So I want to start to raise questions of how we can study the care that meets patients where they show up and where clinicians need to work with providing care for patients with BPD. How can we study the outcomes that we see in our general services to improve what we do on a daily basis? So the questions I'm going to raise, but certainly not answer, is how can we improve the care that patients seek? We need to answer the following or address the following issues, I think, in research. We have to first understand what our treatment targets are according to acuity, length of interventions provided, and the phase of treatment that the patient is in. We also need to understand how we can improve the care that's provided in settings that we don't normally see as effective for the care of BPD, such as inpatient units. We also need to know which patients are likely to improve most from the most intensive interventions, factoring in understandings of predictors from their baseline clinical profile, as well as patient motivation to engage in the kind of care that's offered. And we have to increase access to the first steps of care through scalable forms of psychoeducation and online diagnostic assessments. And in the future, I think we need to do better in developing treatments that target the multiple problems diagnostically that patients have that we attempt to treat with the single tools developed for borderline personality disorder on an outpatient basis, so that we can target multiple problems simultaneously rather than sequentially. So I'm going to start with the task of defining treatment targets. The good news in this area of research is that the controversy about which domain of BPD is most important has died down, because we've come to understand that the symptoms of BPD actually interact. So that we've moved away from the idea that there's a kind of heterogeneous lot of types of presentations, and towards a idea that there's some sort of consistent core to BPD that most patients will have in common despite their differences. Now, we've developed or applied new ways of analyzing the effects of targeting different symptoms from looking at the way that these symptoms network. So network analyses look more at the ways that the different symptoms bidirectionally influence each other. And there have been a growing number of studies. Probably the best of these studies was performed by this group using 3 different samples. 2 are adult and 2 are adolescent. And what they found that I think is really important to hold in mind is that despite the heterogeneity in samples, one being a specifically recruited PD sample, one being a general outpatient adult sample, and one being an adolescent sample that combined inpatients at a local hospital in Houston, as well as community controls, there is still a consistent finding that the central network seems to revolve around affective instability and identity disturbances in all 3 samples, and in relationship instability in adults. So these are the 3 kind of corners of personality disorders that most define its distinctions from other disorders such as PTSD, and also are the central focus of the treatments that have been developed to work for patients with this disorder. In our own study, this was John Gunderson's family study of personality, which recruited over 300 individuals with either BPD, major depression, or non-borderline comparisons, as well as over 700 first-degree relatives. We found the same kind of network. And as you can see from this diagram, the symptoms of BPD influence each other. You see in the bubbles the different symptoms of BPD, and then the kind of thickness of the lines between these symptoms really represents the strength of influence that the symptoms have on other symptoms. So we see here that the central nodes revolve around affective instability, frantic efforts to avoid abandonment, identity disturbances, and relationship instability. Again, this really is central to the focus of treatments for BPD uniquely, and probably explain why they work despite their various differences in focus. But when we look at the treatments in question, we know that many of them work. But if we take a finer grained look, in the most recent Cochrane review and meta-analytics study of the trials to date, we see that the different approaches have limited effects. So while we know that DBT is the most studied of these treatment types and focuses on affective dysregulation, its most significant effects occur in the realms of self-harm, psychosocial functioning, and anger, rather than in affective instability. And similarly, mentalization-based treatment focuses on interpersonal processes, and yet where we see that treatment have the most significant effects are in self-harm and suicide. While we think that these effects of these treatments are derived from multiple dimensions of their approaches, we don't really know what is the minimal effective dose and what are the core ingredients of these very elaborate intensive treatments that make them work. Additionally, we know from this review that group-based psychotherapies seem to have broader effects. There seems to be something about social learning among peers that is quite powerful and needs to be harnessed more in the applications of these evidence-based approaches. But as we've talked about before, the problem with these evidence-based treatments are that they're limited in access compared to demand. The dropout rates across these different treatments is quite substantial. And the non-response rate, as we know from Bringrenier and his students' work, is fairly high. So we need to know better how to scale these treatments and apply them in the right situation. So we've talked a lot about a stepped care or a clinical staging approach. I think that idea really originated in both Australia and Canada, where we need to really harness the broad range of treatment options, regardless of the evidence base, because the evidence base is quite limited. And while we know that there are specialist treatments that have some empirical support for their application, they're not widely available, and they only last for 12 to 18 months at most. But we're going to need more common factors and generalist approaches to spread out over the care people need over a lifetime, as well as starting blocks of care such as psychoeducation or abbreviated treatments when the patient is first identified to need the help related to their disorder. Finally, we need to find longer-term interventions to sustain patients through the functional improvements and recovery that they will need to engage in over a much longer period of time than symptom reduction. So I think a useful way to look at treatment interventions is also along the lines of routine steps of care. This is how the care system actually works. That in step one of meeting patients where they show up for care, we see that they need stabilization. And whether or not we can target these core nodes of BPD or not is unlikely. What we need to do here is a quite different task than what we need to do in steps 2 and 3, which have to do with BPD symptom reduction and rehabilitation from the instabilities of the disorder, as well as what we have to do in steps 4, where the patient has to get a life that can then generate the personality, functioning, consistency, and stability that they need over the rest of their lifetime. And we know that patients with BPD are more vulnerable to negative health, mental health, and social outcomes than other patients. So they're going to need more support and specialized attention over the span of their usual healthcare use. And unfortunately, while we have some tools that work for BPD, they are isolated to outpatient settings. And we know that many patients with BPD will concentrate their interface with care at levels that aren't often compatible with these effective treatments. So this brings me to one of the studies that we're currently in the process of preparing for publication. This is a study on whether or not patients who screen positively for BPD respond to inpatient hospitalization. And part of the rationale for this study was really to investigate these kind of common myths about BPD patients in this setting. While we know that outpatient therapies are the gold standard for these patients, we also know that most patients with BPD will revolve through some acute level of care at some point in their treatment trajectory. And this actually leads to this belief that inpatient hospitalization is bad for patients with BPD. But I think we have to take a closer look at whether or not that's actually true. So we looked at a sample of 753 inpatients who just get admitted to our general psychiatric units at McLean Hospital. And all the patients engaged in a kind of quality assurance battery of assessments that included at baseline a screening instrument for borderline personality disorder, the McLean screening instrument for BPD, abbreviated for MSI BPD, which is a 10-item true-false questionnaire just for screening. And of these 753 patients, about 26% screened positive for BPD. This is consistent with findings from other studies. And these patients were more likely to be younger, female, and have worse physical and mental health, as well as more housing and employment instability. They also endorsed higher symptom severity on all the measures that they completed, including those of depression, anxiety, overall psychiatric severity and impairment, suicidality, and self-harm. So the research team that was headed by Gus Yip and Joanne Chen looked at several questions about common beliefs that we have about patients with BPD in inpatient settings. The first is whether or not they actually had prolonged regressive inpatient stays. And what they found was that patients who screened positively for BPD did not have lengthier admissions and were not more likely to be outliers in length of stay than patients who did not screen positive for BPD. And in addition, they found that these patients actually responded very significantly to inpatient hospitalization. There's something about this support and containment of inpatient hospitalizations that was associated with reduction of symptoms on all measures. These patients were 2 to 3 times more likely to report reliable change in terms of anxiety, depression, and general psychiatric severity levels. And suicidality and self-harm levels at discharge were not different than other patients, but were significantly reduced. And in the figure on the right, you see how much change occurred in the span of, on average, 2 weeks' time in inpatient hospitalization in terms of suicidality and self-harm thoughts. So it brings up the fact that while hospitalization is not the treatment of choice that's going to address the interpersonal and identity disturbances of BPD, it may do a lot to address some of the other nodes of the problem to stabilize patients enough to engage in the next step of care. And it could, in fact, in some ways, if used appropriately, be both life-saving as well as impactful in reducing the challenges to ongoing treatment. So we know that hospitalization provides some safety in asylum, but it can be misused, which is something that I think drives our concern about hospitalizing these patients. But it really provides an opportunity to press the pause button and evaluate the treatment, consider changes when that becomes very fraught in the face of acuity on an outpatient basis. It enables the treatment team to increase family involvement and provide support for carers, and also address situational stressors such as romantic relationship problems, family problems, and work concerns. More importantly, it provides some time and space to reformulate an aftercare plan, and also some stability in which difficult disclosures and topics can be addressed. So more work, in my opinion, needs to be done on how to maximize the use of inpatient hospitalizations. This is something I see at the Spectrum team all the time grapple with, how they can be in consultation to the inpatient teams about how to bridge the care from an acute state to a return to outpatient treatment for these patients. So providing some focus on tasks that can be done in patients, such as diagnosis and psychoeducation as a means of establishing focus and structure. Also a focus on the life stressors that precipitated the stay, as well as a plan for more reliable support given the impact of interpersonal instability on the overall picture of symptom severity. What would also help is increased availability of brief, immediate care. We oftentimes over-rely on long-term care that's never immediately available, but we do know that briefer variants and step-downs of care at this point do work. One model was tested in Canada by Joel Paris's group, which was written up by Lise Laporte, that illustrated that a brief 12-week specialized outpatient treatment provided good enough care for most patients, and extended care that exceeded 6 months was only needed in more severe cases where there was oftentimes comorbid substance use. This brief form of treatment decreased depression, impulsivity, self-esteem problems, emotional dysregulation, and self-harm and suicidality. And continuation to a more extended version of care was only opted for in less than 20% of cases. In Australia, we know that Project AIR has a brief step care model that's even more scaled down with 4 sessions over a 1-month period, which was shown to decrease hospital stays, ER visits, and costs overall. And there was an interesting attrition each session throughout the 1-month period, which suggested that many patients just need stabilization and a bit of support, and then they can move on with resuming their life as they choose to do. This does not mean that they won't recur in the kind of acute settings, but it does mean that for many patients, they are satisfied with a kind of bridge to outpatient care and a plan to thinking about what they'll do after that step. The last variation is this 10-session good psychiatric management approach that was developed and tested in Lausanne. And this is a model that combines diagnostic disclosure, assessment, and initial steps of treatment planning. And it's shown to decrease BPD symptoms, increase interpersonal functioning, and decrease depression. It also increased the likelihood of entering into an longer-term psychotherapy, as well as metacognitive abilities. And this is something that's being now tested against treatment as usual by Uli Kramer and his group. The problem is these briefer variants of care, which would be ideal after acute intervention, they're oftentimes not available. They're still in the process of being tested through research. But oftentimes more intensive levels of care are opted for, like residential treatment. So this is another study that we did on the residential treatment program at McLean, which is highly specialized and highly intensive. It didn't have a comparison treatment design, obviously, but it did look at which patients tended to respond to this kind of approach. I think residential treatment presents a certain opportunity that's an intermediate level of care that has a little bit more content focused on targeting the affective instability, interpersonal disturbances, and identity problems of BPD in a coherent, consistent, and structured way, where the patient is developing an ongoing capacity to be around peers and navigate social situations that aren't based on dependency needs. However, this is a very intensive form of treatment, and we don't know which patients really will most respond to it. So what we wanted to do in our study of outcomes in our sample of over 200 patients, and this is kind of the profile of this sample that was all female because it's a female program, and not very diverse and generalizable, but importantly, somewhat homogeneous in terms of other factors that may have weighed in on treatment outcomes. And we just collected some simple self-report data on measures of BPD, general psychopathology and functioning, as well as depression. And we use this latent class mix effect modeling to explore heterogeneous treatment responses over time, but also estimate their trajectories. And what we found is that there is a distinct difference between two groups within our program, even though this is a program that takes a lot of motivation to come to and a commitment of time and resources. And what you see in this first graph is that there is a distinct group of patients who start with severe BPD symptoms that have a high treatment response that spans a period of about 10 to 12 weeks. And you see in the graph all the way to the right that the rate of change is different from 0 up until 5 weeks, and then starts to stabilize, but then there's another kind of increase in gains up until 12 weeks. So what's important to notice here is while there is a group of patients who are distinguished by their high symptom severity at baseline that are likely to respond to this form of treatment, there's a majority of patients who actually don't have a severe picture in the beginning, that may have more chronic symptoms of BPD that don't seem to actually change very much throughout the course of their time there. This doesn't mean that they don't gain from treatment, but the requirement for residential care to stabilize symptoms of BPD is not present in this group. Similarly, we see the same thing for depression. For those patients who are severely depressed at the starting point of treatment, they are the ones most likely to respond to a high level of care. But then this levels off around the same period of time, 10 to 12 weeks. And we see that there's similarly a group of patients who have kind of a more mild to moderate rate of range of depression that's more chronic, and they also don't respond to this type of treatment because it doesn't actually change the ongoing conditions of their life. But most importantly, when we look at overall psychiatric severity and functioning, we see a different picture, that there are less severe patients who seem to respond more robustly than a more severe and chronic group. So we know that in terms of overall psychiatric severity and impairment, those patients that are most affected may experience the least gains in this time frame. So taken together, these three trajectories really tell us that when you're using an intensive form of treatment that's specialized, selecting for patients who are more severe and have more to gain from such an approach, and actually have some level of functioning and less impairment, they're the most likely to respond. So these findings really say which patients would respond best to this kind of treatment approach, which really also says that patients who have this diagnostic classification, they may not be right for this kind of treatment, despite its intensity and specialization. So we have to be careful about the allocation of resources, because oftentimes I see in clinical practice that people are applying a whopping dose of treatment to someone who's not likely to respond. So we have to do more research in regard of distilling out who will likely respond to what. Lastly, I'm going to talk about dissemination of the basic platform of providing treatment. Currently, we're about to launch a study that's funded by the Brain Behavior Research Foundation here in the US on online video prescriptions. Throughout our experience in the Training Institute, training professionals on basic information about BPD and how to provide psychoeducation, we realize that the burden of learning that systems need to adopt for very busy and overtaxed clinicians who are seeing a broad range of patients. So one effort to make this more accessible is to provide video prescriptions that can be prescribed to patients. We know, as I've been talking about, specialized evidence-based treatments are inaccessible due to geographic specificity and long waiting lists, and the intensity, duration, training requirements of evidence-based treatments limit scalability. So we need something that's low burden and easily added on to routine care. And we think that what works about this is that psychoeducation provides a more adaptive explanation for the patient's problems that destigmatizes those problems for both the patient and the clinician, so that they can generate more hopefulness and a more robust treatment alliance, regardless of what they're doing. Because the person with BPD comes saddled with a lot of negative self-attributions as the reasoning or the cause of their problem, as does the clinician. So having a more adaptive way of seeing the problem, just diagnosing BPD and understanding the illness more objectively, provides a focus of expectation for change in terms of these interpersonal instabilities, identity disturbances, and affective dysregulation symptoms. And if the clinician can help the patient reframe their problems so that they can get the assistance they need to cope more independently in the world, this may actually stabilize them to use life experiences such as in work and love in order to build their personality functioning and sense of self. So what we're trying to do is take what we know works from psychoeducational interventions that have been studied that are summarized here and package them into something that's routinely used in healthcare. Informational videos are routinely used in general settings for informing patients about procedures they'll be undertaking in their care, and they've been shown to be safe, effective, and feasible. We also are adding on neuropsychological testing, feedback, and vocal analysis, because we know that self-awareness is impaired in BPD, and just doing some self-assessment with feedback and a kind of vocal or verbal journaling may help the patient feel like they have form to process things that happen for themselves and get some feedback from the assessment itself in order to orient them to where they are having more difficulties and where they are improving. We know that daily journaling on any topic leads to reduction in self-criticism, self-harm, depression, and suicidality. And preliminary evidence suggests that receiving feedback on neuropsychological testing may be associated with improved quality of life and personal mastery. We're proposing that there's a top-down regulation mechanism of change in this intervention, that affective instability and poor distress tolerance are central features of BPD that link it with impulsivity, and impaired cognitive control underlies this BPD-related impulsivity. So experiences of mastery and increased knowledge from psychoeducation may engage a top-down mechanism of cognitive control and thereby reduce impulsivity. So what we plan to do is something called a sequential multiple assignment randomization trial that not only tests the outcomes of a psychoeducational video intervention versus a comparison in step 1, but also tests the algorithm for switching to adding on the neuropsychological and clinical assessment feedback as a second part of the intervention. So we plan to actually apply psychoeducational videos versus controls, and a control set of videos for a sample of 100 subjects, and then re-randomize them to getting feedback and providing daily vocal prompts on how their day is going to see the effects of these two branches of the intervention. These are some of the measures that we'll be using at the different branching points. They span clinical measures of BPD, general patient health questionnaire of general psychiatric symptoms, as well as a BPD knowledge test. In addition, we're trying to assess changes in interpersonal functioning with the McLean Assessment of Rejection Sensitivity, a 3-item loneliness scale to see the effects of any changes in their interpersonal functioning, as well as a scale of social wisdom called the San Diego Wisdom Scale. In addition, we're going to be doing EMA that includes a neuropsych test. It will be this kind of cognitive performance test of cognitive control that's scaled to be used on a daily basis, as well as an assessment of their interpersonal functioning. And this assessment of their interpersonal functioning will assess where they stand in terms of GPM's interpersonal coherence model, whether they're feeling connected to others, threatened in their connection to others, alone, or despairing. When we build the feedback, we plan to have feedback on BPD symptoms, cognitive test performance, and attention and response inhibition or cognitive control. And it will simply be graphical presentation of their outcomes, how much they change in different measures as depicted here, as well as how they rate in comparison to other people on different tasks and how they're improving in that regard. This is a depiction of their score on the daily CPT, so they can see their variability. And overall, what we're trying to do in this study is provide some psychoeducation about BPD so that the patient can use that knowledge to organize understanding themselves and their problems objectively and productively. Then we'll do the assessment to provide multimodal, periodic, and EMA assessment with feedback that's coherent, relatable, and symptom-based to enable a patient to use the resources they have to get back on the road of personal growth. So this is aimed to increase their understanding of their BPD and the patterns that impact their life, to empower people to have a framework about thinking in terms of self and other interactively. So lastly, I think one gap that I want to address is just the area of treatments for comorbidities. And just briefly, we're developing GPM for BPD and alcohol use disorder because we know a majority of those with BPD will have AUD in their lifetime. BPD traits will predict future alcohol use, even if they don't have an alcohol use disorder at baseline. And both disorders contribute to significant impairment and isolation. Clinically, we find these patients bounce back and forth between the different services for BPD versus AUD without an integration of these treatments. We do know that GPM works for the comorbidity of SUD and BPD, that in the 10-session version, there was a study done by Uli Kramer's group that was published by Penz and Statler that showed that GPM did reduce symptoms, especially BPD symptoms and general symptoms, in addition to increasing the therapeutic alliance in the BPD group. And the BPD symptoms and therapeutic alliance changes were more significant in the BPD and SUD group. And this is a kind of preview of the model that we use in that treatment that not only looks at the interpersonal states that the patient is in that determines their symptom presentation, but also the neurocognitive and emotional processing capacity as affected by their alcohol use, as well as impairments in self-esteem, responsibility, and a coherent sense of self that both disorders contribute to vulnerability in. And lastly, we're building a treatment for BPD and autism spectrum disorders because there are many overlapping symptoms for both of these disorders that make them more difficult to treat and manage for those patients and their clinicians. We know that the comorbidity between these disorders is not exactly as prevalent as the comorbidity of BPD and something like AUD or PTSD, but this presents very serious clinical challenges and decreases global functioning, self-esteem, and increases the severity of suicidality in this population. So therapy for this group must be used with modifications to reduce intensity and complexity of interventions that rely on social cognitive and empathic capacities, given the difficulties inherent in autism. And more research is needed to develop these treatments. But one upcoming paper that contributes to elucidating how this plays out in a clinical case is first authored by Lucas Cheney there at Spectrum, which represents a collaboration that we've had over the year that I've supervised a complex service. And lastly, I want to just touch upon the fact that good psychiatric management for BPD happens over a lifespan. Even though these tested treatments only span isolated periods of time, we have to find a way to build blocks so that we can help people ultimately function better, so that they can build better self-esteem and more stable relationships through life itself. Thank you for your attention.
Thank you, Lois. That was a very insightful presentation and clearly explains how research can actually help improve practice. A couple of questions. First question is about the data that you presented on inpatient treatment. The question is whether were there any readmissions, and do you have any data on readmissions in those papers?
There's not data on readmissions at this point in time, but the patients who were admitted that were BPD positive in their screening, they were more likely to have had another inpatient admission in the prior 3 months. So I think that this is a good question, because understanding the recurrent use of inpatient hospitalization is going to help us understand better how to use inpatient hospitalization either at the beginning of the patient's interface with care to organize it going forward, or just kind of sparingly over time, and identify those patients who actually undergo repeated readmission. Those patients need to be identified early, and interventions to help them reduce hospitalization so that they can build a life outside of treatment that will ultimately stabilize their personality functioning. How that can be done is a kind of area of future research.
So thanks, Lois. There is another question from one of the participants. How do you define severity of borderline personality disorder?
Well, I think the symptom severity that we oftentimes use in studies, it just has to do with the kind of endorsement of high levels of the different BPD symptoms that are being assessed by something like the XAM-BPD. So I think that when patients come into these acute settings and they have, kind of a high level of all of the symptoms, they're all networked, so that it's difficult to decrease the symptom burden for these patients without some sort of situational change. And I think that this is where the kind of inpatient hospitalization in some cases, or an intensification of outpatient services, can stabilize patients given their difficulties of being on their own and managing their kind of broad range of serious symptoms, so that they can kind of then resume treatment as usual. I see teams really expending a lot of energy and resources trying to keep patients, sometimes outpatient, during these times, only to kind of have marginal gains and then prolong a period of more challenging difficulties for the patient. So finding ways to temporize these kind of severe swings, however they're defined, and I think we do have to find a way to define it more clearly across studies, I think is something that could help to preserve resources in clinical services, so that clinical staff don't experience as much burnout.
Thank you, Lois. The last question is, is there any follow-up data for clients who have gone through the Gundersen's Institute, the long-term outcome? Second, if you could very briefly outline the kind of treatments, the duration of treatment that occur at the Gundersen's Institute. Thank you.
Sure. We actually, for the first kind of sample of 217 patients, we didn't really have the benefit of ongoing data collected after their discharge. But what I can say about that treatment, it's mostly DBT, but it combines some MBT and GPM into the treatment. But really, the GPM focuses on getting patients to function. So we hold them accountable to the structure and the expectations of the program. So it's really a kind of setting for socialization, and then using the treatment approaches like the DBT skills to stabilize their functioning amongst peers. So it's something that's an advance from what's expected in inpatient hospitalization. And what we do based on this data that we've collected and the findings is that we really do require patients to get some sort of meaningful activity, like a job or going back to school or some sort of volunteering. after their symptoms stabilize so that they can actually start to go on the path of recovery, not just symptom stabilization. And most patients who leave the Gunderson residence do actually maintain work and go on to stabilize, I think largely because of their roles in the community. Yes, there are ups and downs, but I think the trajectory is hardest for patients who have comorbid substance use disorder and narcissistic personality disorder.
Thank you very much, Lois. I think we are run out of time for any more questions, and so hope you can have whatever weekend left of the day. So we really sincerely thank you. That was a great presentation. We all learned a lot and enjoyed a lot. Thank you, Lois. I now have the pleasure of introducing our next keynote speaker, Associate Professor Giles Newton-House, who will be speaking on should we compel people with borderline personality disorder to have care? A brilliant topic. Giles is a consultant psychiatrist who works in the personality disorder service in the Lower North Island of New Zealand. He is also an associate professor at the University of Otago. He is part of the senior editorial team at the British Journal of Psychiatry suite of journals. He is on the board of Personality and Mental Health, and most importantly, he is also the president of the International Society for Study of Personality Disorders. He also chairs the Australasian Association for Research and Treatment of Personality Disorder, the AARTPD. We are very fortunate to have you, Giles, with us today, and over to you.
Kia ora, thank you, Sata. Kia ora tātou. Ko te aru marangi te maunga. Ko Otari te awa, no te whanganui a tāra hou. Ko Newton-House, ko tō whānau, ko Giles, tōku ingoa. So thank you very much for that kind introduction, Sathya, and thank you. Do you want me to share my slides? Yes, please, he says. Share screen. Share. There we go. Can everyone see that all right? Excellent, thank you. So what I've done is I've just said thank you and introduced myself in Māori. I've told you I'm here in Wellington in New Zealand, and this is indeed home for me. And I spent my time in the northern hills where I used to play as a child and now go travel running. But that's not what I'm going to be talking to you about today. What I'm going to be talking to you about today is this: should we compel people with borderline personality disorder to have care? And so this is what you can expect over the next 30 to 35 minutes. I've tried to make this a little shorter than the allocated time, so there's plenty of time for questions. And I'd really encourage you to ask questions as you'll discover. This is something which I spend a lot of time thinking about. So you're going to hear a bit about me. I want to base this in a clinical case. And then we're going to have a think about the number of people this might affect, what some of the ethics behind this might be, and if compulsory care is indeed a good idea. So let's start with a little bit about me. So I do quantitative research, but I also do qualitative research, and I think positionality, understanding where someone's coming from, is really important, and hopefully that will help you to understand how I think about this topic. So I think first and foremost, I'm a clinician. I see myself as a doctor first, and obviously there are important parts of that about providing care to my patients. If I can't see a line that goes from what I'm doing to improving the well-being of my patients and patients more generally, then I don't think I should be doing it in my day job. And so I guess all of this derives out of a desire to try and improve the lives of the patients in front of us. I work at, as Sathya rightly said, thank you, Sathya, in the Department of Psychological Medicine at the University of Otago as well. And so clearly I have an academic bent. And the empirical work I do here is both quantitative and qualitative. As well as that, I'm an affiliate of the Bioethics Centre in Dunedin, also part of the University of Otago. And And so, as well as thinking about empirical questions and answers to those questions, I guess we try in the Bioethics Centre to think about how those questions might be framed more broadly. And I think when it comes to questions like, should we compel people into care, being able to think through the ethics is as important, or possibly even more important, than looking at some of the empirical data. And as Sathya rightly said, I'm also part of the International Society for the Study of Personality Disorders. That's a really great group of clinicians, researchers, and now carer and consumers. And I would encourage you all to think about joining ART-PD here in Australasia, and coming next year to ISS PD 2023, the Congress we will have in Sydney. It's a great opportunity to meet people working in the field, and to meet people who are, I hope, benefiting from some of that work. So now I'm going to present a case to you. I'd like you to hold this case in mind. This is not a real case, and the reason it's not a real case is because I don't have the informed consent of one of my patients to present it to you. But it's a case that I hope is understandable to many of you, no matter what your position is. So I want you to hold in mind a 23 young Caucasian woman who's well known to mental health services and has a diagnosis of borderline personality disorder. Unsurprisingly, she also has a diagnosis of depression and ADHD, and possibly a diagnosis of PTSD as well. And she presents yet again to the emergency department following an episode of dangerous behaviour. It's behaviour dangerous enough that people have hummed and hawed about whether she needs ICU care. And again, she refuses all intervention in ED, in ICU, and indeed sometimes your colleagues in mental health inpatient doctors want something done to help her, because it feels like she's coming back in again and again and is not being helped. And this raises the question of whether we should make her, Ms. A, accept care. So should we compel her with mental health legislation to take treatment? Well, so before we approach this question directly, I think it's important to have some idea of the epidemiology behind this. Do we actually compel people with personality disorder into care at the current time? Does it make a difference? What do we know from the data we have? So let's have a little bit of a look at that and see what the data we have at the current time tells us. So just so we're clear, what I'm mostly going to be talking about here are the North and South Islands, and data from the North and South Islands, not data from the Big Island of New Zealand. And that's because it's the data I'm most familiar with. What I can tell you is that almost all of what you hear today is extrapolatable to the various jurisdictions in the Big Island as well. So even where legislation is a little different, and we will touch on that briefly later, much of the trends that we will talk about in terms of this data have been mirrored in the studies that have been done in the various jurisdictions of New Zealand's Big Island. So let's start off with how common is personality disorder? Well, this is an interesting question and one that varies, and I think that is something that's worth bearing in mind. So the ECA, the Epidemiological Catchment Area Survey in the States, was one of the earlier studies that took a look at this, and they thought somewhere between 5 and 10% of the population would have a diagnosis of personality disorder. It's worth noting they only looked at a relatively small proportion of the population, minuscule really. And so following on from this, the NESARC study also asked the same sort of question. Now you'll see here, NESARC had a much, much bigger population, 43,000 or so. And so it's a great size of population to ask this question, although it has a number of difficulties with it. It's a structured tool. It's asked by lay researchers. It's cross-sectional. And interestingly, this study came out with a figure of nearly a third of the population would qualify for a diagnosis of personality disorder. Now, obviously, something unusual is going on here because a diagnosis of personality disorder in the ECA can't be the same as a diagnosis of personality disorder in NESARC. The epidemiology does not make that allowable. They're just too divergent. And Trull took a look at the NESARC data and realized that what they had done cross-sectionally was to look for impairment in one functional domain And by looking at impairment in 2 functional domains that Trull and his colleagues felt more closely represented the clinical reality of personality pathology, this figure was reduced to just under 10%. These epidemiological general population numbers have also been looked at using the WHO Mental Health Survey, and they've done that across more than 10 countries now. And this gives us figures of something like 1 in 50 to 1 in 14 people in the community would fulfill criteria for one personality disorder. Now, this is starting to get a little bit closer to the sort of clinical personality pathology we might think of. And the reason for that is because the way the WHO Mental Health Survey worked is if you cross the threshold for an Axis 1 disorder, then they did Part B, looking for personality pathology. But they only looked at it in people with it for personality pathology in people with an Axis 1 disorder. So it's not really a general population. It's closer to a clinical population. Now, what you can see from these various figures and how broadly arrayed they are is that there's something unusual going on with how personality disorder is described here. And when we look at the literature and you hear people talking to you about studies with personality disorder, the question you probably need to ask yourself is, what do they mean by personality disorder or borderline personality disorder, which is usually slightly more accurate. And what these don't seem to do is answer this question very well. And so as a clinician, I am interested in knowing general population figures, but I really want to know how common Ms. A's personality disorder is from a clinical perspective. This helps me to think about how much time and energy I need to be thinking generally to support people like Ms. A. So what we need to do that isn't large-scale studies with trained lay researchers asking very structured questions. What we need is real-world figures. And by having real-world data, we get to find out what is actually going on. So together with our colleagues, Ruth Cunningham's an epidemiologist here at the University of Otago Wellington, and June Atkinson is a statistical whiz, we took a look at this. So what we did was we looked at it's called the Program for Integration of Mental Health Data, or the PRIMED data set. Now this data set is a national mental health data set. Every single secondary mental health service provides information to that. Psychiatry in New Zealand is essentially entirely within the public health sector, although the single private hospital in New Zealand also provides data to PRIMED. PRIMED looks at adults between the ages of 18 and 65. And because when we did the study, what we were interested in were people like Ms. A, we limited the people included in the study to people who had contact with mental health services across at least 3 months. So people who had a single contact and distressed and might skew the data weren't looked at. And so we examined how common personality disorder was in this whole of nation data set using a 10-year time period to kind of help give us a nice clear idea about that. And what we found was it's pretty common. So about 3% of people who present are given a diagnosis of personality disorder, formal primary diagnosis. So half of those people diagnosed with borderline personality disorder. And as you can see from the graph down here, almost everybody received a diagnosis of either borderline personality disorder or antisocial personality disorder if you're a man. The other personality disorder types were almost never diagnosed. And again, from a clinical perspective, I think that is a useful takeaway that clinically we see borderline and antisocial personality pathology. We tend not to see these other types of personality pathology, at least here in New Zealand. We were also interested in whether personality disorder, as we see it in secondary mental health services, occurred in the presence of another mental disorder. And unsurprisingly, what we found here is it did, commonly, and that there were commonalities by gender. So as you will see here, and we would expect, internalizing disorders, depression, anxiety, and related disorders were most commonly comorbidly diagnosed. However, and segues quite nicely with Professor Lois Chan's talk, there's particularly significant overlap with substance use disorder as well. I thought it was interesting that there was a clear minority of people who also had psychoses as well as a comorbid personality disorder and borderline personality disorder. So what does all of this tell us? Well, I think what this tells us is the presentation like Ms.A. is not uncommon in the real world, although it's certainly not the most common thing we see in mental health services. So I think maybe 1 in every 100 presentations with a mental health problem will be a presentation like Ms.A.'s. So not the most common, but clearly not so uncommon that we shouldn't be focused hard on how best to manage Ms.A. We see Ms.A. has a second diagnosis, and this is absolutely the norm. And again, I think this is worth thinking about because much of the treatment evidence we read, particularly in more structured trials, may not have people with multiple diagnoses or so obviously have people with multiple diagnoses included. And it makes generalizability to someone like Ms.A. a little more difficult. So I don't think this is as straightforward as saying, get some DVT or get some GPM. This is about thinking about the art of medicine as well as the science of medicine, all of which is great, except what does this mean if Ms. A, having presented to ED, then refuses care? Well, now we're going to change tack just a little bit. And to perhaps, I'm going to talk to you just a little bit here about compulsory care, particularly compulsory community care in New Zealand, to give you an idea of how this works and how common it is. And I guess the reason that this is important is because, like every jurisdiction in Australia, New Zealand has a Mental Health Act. Most jurisdictions around the world now have a Mental Health Act that allow for outpatient, compulsory outpatient treatment as well as inpatient treatment. When we think about Ms. A, the inpatient treatment section and outpatient section treatment, both are important. Often it's the accessing and maintaining treatment in the community that is of most interest to our colleagues. And so where people kind of wonder what's going on. And so with other colleagues here, so Ben Beagerhole, who I actually went to secondary school with, is a consultant psychiatrist in Christchurch, and Chris Frampton, another statistics whiz in Christchurch. We took a look at the New Zealand databases looking at compulsory care, which is collected by the Ministry of Health. And we looked at a variety of different things. And in this paper here, what we were most interested in is outcome. So if I'm going to detain Ms. A, is it useful? When we talk about outcome in this sort of research, the outcome often used is hospitalisation, the concept being that hospitalisation is a loose proxy marker for being unwell. And I think this is the first and most interesting thing possibly to share. So we divided patients by psychotic and non-psychotic disorders primarily because community treatment orders, when described certainly and enacted legislatively, and this is true in New Zealand, Australasia, and the UK, are designed for, primarily talked about as being designed for people with psychosis. However, it wasn't only people with psychosis who are able to be detained using this legislation. And so what this gives us here is a rate ratio, how commonly you end up in hospital on a CTO compared to being off your CTO. And so the key line here that I should have drawn across but didn't is at 1 here. Essentially, if you sit above the line of 1, you're in hospital more on a CTO than off it. And if you sit below that line, you're in hospital less often. And I think the thing to notice here, particularly with non-psychotic disorders, like personality disorder, you're significantly more likely to end up in hospital if you're detained than if you're not detained. And so we wanted to look at this a little bit more closely, and we wanted to consider this in a little bit more detail by diagnosis. And so we took this data set again and looked at it, this time looking more closely at the various diagnostic categories there are. Just going to see if I can move this so I can see the slide a little bit better. And so I guess this is the first thing to notice. This is the characteristics of this study population. And particularly, this is the part of this to take a look at. So what you'll notice here is that if you're detained under a community treatment order and you have a personality disorder, you're going to be young, you're going to be Caucasian, not Māori, you're going to be a woman, and you're going to be detained often, even if not for quite such a long period of time. And so there's some things to notice here. So if we think back to Ms. A, do we detain people with personality disorders? Well, yes, we do. Are they young white women? Well, yes, they are. And if we look at this in a little bit more detail, so every talk needs a legible slide of a table, and this is mine. But this here is the key figure. And if you look down the column of outcome variables, what you see here is if you're admitted to hospital 3.5 times on average, if you have a hospital, the outcome being hospitalization here, compared to if you're not. So do we detain people with personality disorder? Yes, we do. Which patients with personality disorder do we detain? We detain young white women. And is that relevant? Well, it's highly relevant when you think about the overall population of people who we detain. And the reason for that is that we detain 4 times more Māori than Pākehā, and we detain 3 times more men than women. So what we see here is a significant outlier compared to overall detention figures. And so there's something about this group which is generating concern in a way that leads to lots of compulsion. And so I guess that raises the question of whether this is a problem. Maybe it's that young white women with a diagnosis of personality disorder, like borderline personality disorder, need to be coerced into care, and they need to be on a CTO. And I think there are 2 important ways of thinking about this. And so the first one I want to think about is this okay, is from an ethics perspective. So what might be the ethical problems or benefits of compelling someone into care? When we think about ethics, I often think about international and national law and convention. The law and convention nationally and internationally being a reflective of what we as a larger society deem to be appropriate. So the Convention on the Rights of Persons with Disabilities is a United Nations Convention. It's been in existence now for about 16 years, and both Australia and New Zealand are signatories to it. The Convention of the Rights of Persons with Disabilities essentially says that people with a disability, and within that definition, they include people in psychosocial distress, i.e. people with mental health problems, like the sorts of problems I might see as a psychiatrist, or like Ms. A has, should be afforded the same human rights as everybody else. Now, on one level, this seems absolutely obvious, but when it comes to looking at our laws, and by becoming signatories of this convention, we have made promises to change our laws to match it. Many mental health laws don't do this because they provide for compulsion into care in a way no law does for other health problems. So it's considered discriminatory legally and something that needs to be addressed. If we think about it from a more broadly bioethical perspective, these here are the 4 principles of bioethics. Beecham and Childress are the people who dreamed this up, and certainly this is the prominent bioethical typology. It's the common way we think about bioethics in medicine. So Beecham and Childress stated they felt all 4 principles were equal, although it's very clear over the last 3 decades that autonomy has become the king. If we think about the CRPD, when they talk about respecting the will and preference of people, they talk about respecting people's autonomy. But also, the principles of non-maleficence and beneficence require some stuff of us. So if we're going to compel someone like Ms. A into care, we need to be sure there's evidence that what we're doing is good. But we also need evidence or support to say what we're doing does no harm. I think importantly here, we can't ignore the issue of justice in constrained public healthcare systems. there will always be more demand than there is capacity to supply. And questions are raised about how we distribute our healthcare resource, particularly for people who don't potentially fulfill the standard behaviours we'd expect of a patient or the behaviours expected of illness. And people like Ms. A would certainly fall into this, at least by the perspective of my ED, ICU, and sometimes inpatient colleagues.
So there are two general forms of mental health legislation. These are both based on the concept of disorder having a mental illness. The older school style of legislation considers disorder and risk. This means to be detained, all you need to have is a concern of a clinician as well as a disorder. This clearly is in breach of the CRPD, and some jurisdictions in Australia have subsequently amended their mental health legislation, and we are indeed in the process of reviewing ours. And where this has occurred in Australia, we have tended to end up with a disorder and capacity legislation suggesting that if you have a mental health problem and you lack capacity, then you can be detained. The problem seems to be, at least initially, looking at prevalence figures as if nothing has changed in terms of use of the Act. Some people think that this might be because there is a collapse of capacity into risk. In other words, I am worried, if you don't agree with me, what you're doing is risky, you must lack capacity. You can see that there is a circularity to this, which doesn't address the questions that are raised. So if we think about Ms. A and we look at these two sorts of mental health legislation, then we can see that certainly using a disorder and risk type approach, such as we have in New Zealand, there would be no problem about compelling Ms. A into care. She clearly has some sort of disorder of mind, and certainly when it comes to risk, I think few people would consider this.
Sorry to interrupt, Giles. We're not able to hear you clearly.
I've done nothing different. Can you hear me at all?
We can hear you, but not very clearly. The sound quality has dropped.
Hey, are you sure it's nothing
Yep.
at your end, Satya?
Now it's fine.
Okay.
Now it's fine. Thank you.
Okay, I'm not sure what happened there.
Thanks.
Shall I just plow on?
Yep, I think now it's clear.
Okay.
Thanks.
So if we think about someone like Ms. A, then she clearly would be able to be detained using a disorder and risk type legislation here. But even if we think about this from a disorder and capacity perspective, it's not difficult to make an argument that we could compel her into care. She seems to have behavioural problems. Psychiatrists say she has a mental illness. We can't really be sure cross-sectionally that she seems to be weighing and understanding the information available to us. And in fact, I've made the argument in the literature here that we should possibly have some caution when it comes to thinking about how we help people with personality disorder in acute settings such as that of Ms. A's. The worry here being that maybe what we are not seeing is an expression of someone's true autonomy at times of severe distress. And if that is the case, perhaps for a short period of time, we should be looking to support someone to return to their decision-making abilities and be cautious about simply allowing them to have their stated preferences heard. But that's not certainly the only ethical approach to take. So if we also think about the benefits perspective, we need to think about whether detaining somebody using mental health legislation actually makes a difference. I mean, does this help people? Well, that's a difficult question to answer and is broad. And certainly when we've looked at this from a literature perspective, we think about how this might help or harm someone, think about those two ethical principles. From a harm perspective, we can be really clear that if you detain someone using mental health legislation, They feel significantly more coerced into care. So anecdotally, people sometimes say, people don't mind being detained. And actually it's okay and provides a safety net. Well, the literature certainly wouldn't suggest that's true. And then if we examine the qualitative literature, and this is a study I did a long time ago, looking to see what sort of responses people have to being coerced into care, what we see here are these themes of disrespect, dehumanization, violations of integrity, and sort of loss of human contact, isolation. And if we think about our patient like Ms. A, we can see how terribly bad these might be for her in terms of outcomes. These are genuinely harmful for people who have difficulty in making connections with others, have difficulty in maintaining an internal sense of self, and who possibly have traumatic backgrounds. And from a trauma-focused care perspective, it's very difficult to see how coercing someone into care can fit within a trauma-informed setting. And so I think this tells us something very worrying about the potential harms, even if we are able to potentially compel someone like Ms. A into care. But I guess the other thing we need to think about is, I guess what I, at least, and many others would consider to be one of the worst outcomes, which is dying by suicide, or at least dying young. And arguments are certainly made and routinely made in an emergency department with people like Ms. A that by detaining someone and certainly compelling them into acute care, we prevent this outcome. Now, this is work we've done, again, looking at the whole of New Zealand over a 10-year period. And what we've tried to do here is understand if community treatment orders particularly actually reduce mortality. And the reason we've looked at that is because that might be a powerful argument for their utilisation, mortality being considered a pretty bad outcome in medicine. So we haven't published this study yet. And interestingly, this study suggests actually that you're about 3 times more likely to die on a CTO than off it. Now, there are different ways of understanding that or interpreting it. One being that people might be a lot sicker when they're on their CTOs, and that might explain some of this, but we're not quite sure that might be the case. As you can see here, we've been able to look at this particularly for people with personality pathology, and this is a tiny sample, and so we're also not quite sure how to understand this. So this is 6 total suicides in a 10-year time frame. So in that 10-year time frame, there are about 3,000 suicides in New Zealand. So it's a very small proportion of a low incident behaviour. And certainly to my mind, I'm not clear from these findings alone that this would be justification for some of the other potential problems related to compulsory care. So what do we do with Ms. A? What should I be doing? What's the right thing to do? Well, I mean, I think what the evidence tells us is that if we treat her under compulsion, if I make her take care, she will likely feel compelled. She will likely feel disrespected, humiliated, disregarded. So this is clearly not trauma-informed or trauma-caring care. She'll likely end up in the hospital 3 times more than other detained patients. So it's going to have a larger impact in terms of disruption to community care. And I'm not clear that there's any benefit, particularly, you know, I think about this with my ED colleagues, that this is going to improve her overall mortality. So, and if we do treat her under compulsion, if we make her take care, I think we potentially are at risk of being in violation of our CRPD obligations, particularly if she has the capacity to refuse. And we may in fact be in violation of some mental health acts in Australian jurisdictions. But I would hazard a word of caution here, because it's not clear to me, at least, exactly if capacity in a cross-sectional sense here reflects autonomy. And if it doesn't, questions can be asked about whether it's the most appropriate thing to be thinking about when we think about overall care. And so irritatingly, for those of you listening, and I apologise for this, I don't have answers to this yet. But I do think the evidence can inform what we do on a case-by-case basis. What I am sure of is we can't predict very bad outcomes, such as suicide. What I am sure about is this does not prevent good assessment at each point. I think the evidence tells us that compulsion is harmful for people with personality disorder over long periods of time. However, the caution I add here is that it might be necessary in the very short term. And so I think each occasion here requires careful consideration of both the ethical potential harms and benefits, as well as what the evidence tells us about compulsion. And that's all. Thank you very much.
Thank you, Giles. That was a very interesting presentation. Certainly something that we face on a day-to-day basis for which we don't have answers. There is time for a couple of questions. The first question from one of the participants goes like this. Could you comment on some of the issues around compelling someone with BPD to engage in psychotherapy who is perhaps ambivalent about engagement? I think you covered this topic, but I think this is more about, particularly about psychotherapy.
So I think that's a really interesting question. So something I didn't mention is I'm an addiction psychiatrist by training. And interestingly, what the evidence tells us in that area is compelling somebody into some addictions treatment actually works. So that's not true all the time, but it is true for some people. And so there is some kind of face validity to suggesting that maybe if we compelled people with borderline personality disorder into care, that may ultimately be a benefit to them. However, certainly my reading of the literature would suggest that's absolutely not the case. And so I definitely don't think we should be compelling people with personality disorder into therapy, which does not mean we shouldn't be following the sort of approach that you see in therapies like dialectic behavior therapy, where there is a very strong focus on, in that particular form of therapy, it's called pre-commitment or early engagement work, that really understands that there may be difficulties with trust and maybe difficulties with being able to form a relationship. So I don't think we should be compelling people into care, but I do think we should be working very hard to engage people into psychotherapy. And we know that psychotherapy is the key modality of treatment for people, particularly with borderline personality disorder.
Thank you, Giles. I got a couple of questions and a couple of reflections. We have at Spectrum, we have had experiences where the court actually ordered an individual to seek treatment from Spectrum psychotherapy. We were very reluctant to be part of it, but it was a court order. We didn't have a choice because we provide long-term care. The first 6 months, we were not convinced that the person wanted to come to Spectrum for treatment. But however, in the long term, it was beneficial. The person actually found it useful because we took a stand saying that if you want to, we'll do it. And surprisingly, that was useful. We've had a similar experience with a forensic client where the person was told by this panel that unless they sought treatment from us, they can't get discharged. Perhaps there was an incentive, but in both these instances, initially the engagement was very tenuous, and we found it very hard to take up therapeutic work. But in the long term, it was positive for us. I just want to reflect on one of the papers that you presented, where you spoke about cautiously using the compulsory care in some circumstances, if it can be life-saving. Could you expand on that a little more?
So I would encourage you never to think of compulsory care as life-saving, because I think it's commonly understood when we say that we somehow have a magical power to predict that someone is going to, say, die. And by using this piece of legislation, they live, and therefore this piece of legislation is incredibly important. And that's a fallacy. Nonetheless, undertaking a good assessment of somebody who is in acute distress is a really important and integral part I personally think of all clinicians. So I've been working for a couple of years now with philosophy colleagues of mine, trying to conceptualize why we think capacity is so important. And I think the reason for that in medicine is that it reflects autonomy, our kind of internal sense of self, who we are, what it means to be uniquely me. And the reason we have a default to say you're capacitous as an adult in healthcare, and so we can only treat you if you agree to it, is because we have a default that says your capacity reflects your autonomy. Actually, I've wondered if that is true for some people with borderline personality disorder, particularly at moments of high psychosocial stress. And that tends to be times we see people, say, in the emergency department. And so I guess my caution is someone may temporarily and cross-sectionally fulfill tick box criteria for capacity. However, that capacity may not be reflecting what are their true will and preferences or a conception of that. And I think if we look at some of the modalities of psychotherapy that help people with borderline personality disorder, what we're actually doing is helping to build an integrated sense of self. We're helping people to develop autonomy. And we do that by ways of helping people to integrate emotions and behavior. We do that by ways of helping people to develop an understanding of other people's mental states. We do that by ways of helping people to understand what constitutes normal behavior in the community. So I actually think what we're doing potentially, from a totality perspective, is actually helping someone to become more autonomous in their own personal growth. And as that occurs, I think medically it makes increasing sense to understand the capacity they might have.
Brilliant. Thanks for that explanation, Giles. There are a couple of more questions. I'll just read out. What are your thoughts on how your findings fit with Dr. Lois's discussion regarding the positive gains people with BPD report following inpatient admission?
Yeah, so that's an interesting one. I don't think that's always the case. Certainly, what I do think is the case is that inpatient units are idiosyncratically quite different. And so I'm not sure all inpatient units are born equal. To give you an example, where I work in Wellington, our inpatient unit, we have the lowest number of inpatient beds per 100,000 of any province in the whole of the OECD. It's a difficult place to be. And I don't think people with borderline personality disorder who are admitted usually find that helpful. The caveat I have is that as we understand people and develop plans with them, from time to time, the inpatient unit does exactly what they need, which is provide asylum at times of acute environmental distress. And so that's why in my last slide, I described this as idiosyncratic. I think it's something where the evidence doesn't help us too much, and we need to build it up with individuals over time.
Do you think one day in the future, when we can have evidence-based treatments, psychological treatments available in the community for everyone with a diagnosis of personality disorder, then we would probably have no need, or in a very, very limited circumstances, even this question of compulsory care would come up. And hidden within that question is the fact that are people refusing care because our care doesn't really match what they need, and our settings, treatment settings, really not appropriate for people with borderline personality disorder?
Well, I think particularly maybe just a little bit more broadly than borderline personality disorder, if you have a high adverse childhood experiences score, your understanding of life is one of trauma in some form, then that leads you to have some caution about engagement with the world. For a subgroup of those people, personality pathology is the outcome. And so I think for those people, being able to develop a way of engaging which develops trust is really important. I want to move to this country that provides perfect public health for everybody, because I think I'll ride to my clinic on a unicorn. But I do agree with you, Satya, that I think if we did better at listening to our patients and where their needs are, we would deliver a better service. And I'm you know, without wanting to blow your horn for you, what Spectrum offers where you are massively outweighs what we offer where we are. And that is in part related to resources and funding, as well as the technical skills you've built up over time. And so I think there is a strong I have a strong sense that you're probably right. And arguably, if we are compelling people into care, the care is always in brackets because it's care according to whom. And so somehow I think if we're able to work with, not do to, as you suggest, we're going to get closer and closer to what is genuine care in the long run.
Thanks, Giles. There's one more question from one of the participants, probably the last question. This is probably not directly related to the presentation, but possibly in your role as the head of the ISSPD. The question goes like this. In Australia, we have the National Disability Insurance Scheme, NDIS. People living with borderline personality disorder may qualify if their functionality is severely impaired. The disability scheme is not about the diagnosis, it's more about the functional impairment. But to become a participant under the scheme, the person must prove that they have engaged in all evidence-based treatments and that they are not likely to improve their functionality with further treatment. So they need to prove that they can't really improve clinically. So many people with very low functioning have not engaged with the Spectrum or any BPD specific therapies. This precludes them from disability supports. I would like to hear your thoughts on this. It's more it's a general question because which we grapple with even within our field, because although it is not diagnostic specific, people with borderline personality disorder for some reason have more difficulty in accessing the insurance scheme than others.
It's a really interesting question. Obviously, I don't live in the big island of New Zealand, so it's difficult to speak to exactly. We have ACC, which is a national insurance scheme as well, and when you read that act, it's clearly written for somebody who trips on the footpath and breaks their arm. And I suspect that your National Disability Insurance Scheme is written in a similar way. And of course, the difficulty in an area like ours, as Sathya will know, is how do we make sure we can deliver high quality treatment everywhere all the time? And we are very reluctant to say you're going to be permanently impaired. And I think that adds a real challenge because although those comments might be evidence-based, what we may inadvertently be doing is essentially stigmatizing you because the act is written in a way that does that. And sometimes this is a very difficult tension for medical experts who are asked to work in a medical legal sense, is how do we avoid that kind of stigma and avoid that kind of sidelining of vulnerable groups like people with personality disorder, whilst at the same time act as a medical expert in a legal context, which places quite significant constraints around what we can do and what we can say. And like Sathya says, I think that is a real tension if you're engaged in this work, which isn't a reason not to engage in this work, but it is a reason to be thoughtful about how to do that and to do things like lobby for change. And if that doesn't work, take your government to court, which is what I'm doing at the moment. So there are ways of doing this. I mean, I think it's a really important question. I think we need to be engaged as experts, and I think we need to advocate for processes and legislations which are equal and don't stigmatise and don't discriminate.
Yes, we come to the end of the time. Would you like to quickly remind people about the ISSPD conference?
I would, and look, I should have, and I will see if I can find a slide. I usually have this up with me. So every 2 years, the ISSPD has a Congress. This Congress is an opportunity for initially researchers, but now researchers, people with a lived experience, clinicians to come together. I'm just going to see if I can share my screen with you. And can you see that? It's the opportunity to come together, to talk, to share stories and narratives, and to listen to some of the cutting edge research that's been undertaken. So we're holding this in Sydney. It hasn't been down under here since 2011. I can tell you we've invited 45 of the world's experts in the area of personality disorder to come and present their cutting edge research. This reaches from sort of neurobiology and complicated, I have difficulty understanding its science, to things like taxonomy and treatment. So my hope is that this conference offers us a fantastic opportunity to meet, to engage with each other, to understand what is happening, and hopefully to grow and do better for everybody who's struggling with personality problems. So I look forward to seeing all 180 of you there in 12 months' time. Thanks for the opportunity, Satya.
Thank you, Giles. That was a wonderful presentation. Thank you. I now have the pleasure of inviting Professor Gillian Broadbeer again. Gillian is going to present on crisis-based responding to the needs of people with borderline personality disorder, breaking the cycle for better outcomes. Over to you, Gillian.
Marvellous. Thank you, Satya. And what wonderful presentations from both Lois and Giles just now. One about what treatment to give and one about should you force treatment on people. So I'm going to take a slightly different tack with my presentation. And I'm going to talk about 3 of the studies that we've published, or one's close to being published, looking at crisis-based responding. And I'm going to weave those together and then propose some ways that we can help break that cycle of crisis-based responding to deliver real outcomes and have people no longer trapped in the whole ambulance emergency and potentially coronial outcomes. So just, there we are. Okay, so just to set the scene, this is familiar to many, so there shouldn't be any surprises here, but I just want to give you a context. So as we know, the symptoms associated with BPD often usually include emotional lability and interpersonal difficulties, which when activated may culminate in intense and distressing emotions. Now, in the absence of skills or psychoeducation, we tend to cope in whatever way works for us, and sometimes those ways are maladaptive and may result in non-suicidal self-injury, drug overdose, or suicidality. So we know from our own work and from the broader field that 60 to 90% of people who have the BPD diagnosis have a history of self-harm, and they experience suicidal thoughts and may make multiple suicide attempts. And up to 10% people with this diagnosis will die by suicide. This is often preceded, though, by a long history of non-fatal self-harming injuries and involving emergency services, and especially during periods of high symptomatic acuity. So I'll go on to the start of the cycle. So as we know, the ambulance services provide 24-hour, 7-day-a-week emergency care. So they are first responders, and they're often involved in situations involving life-threatening behaviours. Now, paramedics, even though up to 10% of attendances involve a mental health presentation, paramedics are generally not mental health trained, and it's very unusual for mental health specialists to be part of a paramedic team or part of the consultation around those emergency call-outs. One study we've done over the last 3 or 4 years is looking at the utilisation of Victorian ambulance services, and this is specifically for people who the paramedics noted at the scene there was some involvement, there was some relevance of personality disorder. So rather than throw you straight into the data, I'll just give you a quick look at what the main findings were before we look more closely. So we are very fortunate here to have access to the National Ambulance Surveillance System, which is a coded system that's run by Turning Point Drug and Alcohol Services, which is a sister organisation for us, which codes ambulance attendances that have a mental health primary reason for presentation, drug or alcohol, or self-harm and suicidality. So this is a subset of all ambulance attendances in Victoria. And the data we're drawing from is coded attendances from the last 6.5 years. So just from that subset, there were nearly 77,000 ambulance attendances with those mental health or drug and alcohol related causes. And of those, nearly 10,000 were for people who the paramedics identified at the scene had a presentation that was something to do with personality disorder. What we found when we looked at all of those different attendances was similar to what Giles was talking about. They tended to be younger and female, and the majority of those presentations involved the very familiar crisis-driven presentations, such as suicide attempts, ideation, self-harm, and drug and alcohol intoxication. Now, one of the things that this data set enables us to do now is look at reattendance, so the same person getting repeated ambulance call-outs. And we noted for people whom personality disorder was noted at the scene, 8.3% of those people accounted for nearly 50% of all ambulance attendances during that 6.5-year period. And I just want to point out, because that links nicely into our next study, most of those ambulance attendances to people with personality disorder resulted in transportation to hospital emergency departments. Now, this is a quick look at some of the data. I've tried to make it a little bit easier by putting some of the key points in red font. So you can see in the top of the middle column is any personality disorder. So the only two coding opportunities that our coders have is either BPD or other personality disorder. And so we combined the two, particularly since we saw with repeated attendances, sometimes it was other personality disorder and sometimes it was BPD for the same people. Okay, and then in the rightmost column, we have all other mental health disorders. So you can see predominance of women under personality disorder ambulance attendances. And over here on the underage group in the red, got predominantly younger age. And then at the bottom, if you look at the average number of attendances on an annualised basis, you can see it's more than double for people with personality disorder being noted at the scene. And then if you look at the whole 6.5-year period, it's almost 4 times as high. So when we think about the primary reason for ambulance attendance, I'm not going to spend too long on this, but if you look at the self-harm and suicide related behaviours at the top here, for the any personality disorder ambulance presentations, more than half, that was the primary reason for the ambulance call out of something to do with suicide and self-harming behaviours. At the bottom, I've highlighted police co-attendance, which is more likely to be the case when it's personality disorder related call out, and a high proportion of whom are transported to hospital. Now, in terms of the attendance, if you consider that from an individual consumer perspective, what we found was more than 70% of consumers for whom personality disorder was noted at the scene required ambulance services on more than one occasion. Okay, and when you compare that with consumers with any other mental health disorder, it's more than double. Actually, it's not more than double, it's just under double. However, 8.3%, a very small number, admittedly, and I think we need to hold that in mind, it is a small number, receive ambulance services 20 or more times during that period. You know, in Victoria, I think of many parts of Australia at the moment, we have quite a few issues with insufficient services for the demand. And so the thought of people repeatedly requiring ambulance attendance during a time of scarcity really adds to the pressure on the system and highlights the need to somehow intervene to stop this harmful cycle. So if you look at it from an all attendance perspective, the 798 most frequent ambulance service users, so that's people who've required ambulance services 20 or more times, the total number of services that they received, 798 people, with 38,000 call-outs during that 6.5-year period. And this is the one that was representing nearly half of all attendances for people with personality disorder. And if you compare that with all other mental disorders, 202 people used it 7,000 times, and that was only 11% of all attendances. So clearly there is a very much diagnosis-based requirement for emergency services. So what we learned from conducting this study is that despite personality disorder being noted as clinically relevant in only 4.3% of coded attendances. So that's the mental health and drug and alcohol related attendances. Those personality disorder presentations accounted for a disproportionately large number of self-harm, suicide attempt and suicide ideation presentations. And 2/3 of people noted to have personality disorder required ambulance attendance 3 or more times per year. And this, to us and to many, highlights the needs for better and timelier access to appropriate treatment services to reduce the incidence of these mental health crises. Just wanted to point out too that because we're reliant on non-mental health trained paramedics to note down in their notes, which are later typed up and recorded and then coded, the personality disorder was involved in the presentation. This is likely quite an underrepresentation of reality on the ground. So the next stop is the emergency department. So as you saw, the majority of people, ambulance attendances, get transported to the emergency department. And we conducted a retrospective audit of emergency department presentations in 3 hospitals in our catchment. And we also looked at reattendance, okay, both from a yearly perspective as well as from the time that the records were kept, which was about 6.5 years. So we recorded, there were recorded 150,000 ED attendances. This was during a single year, so very busy ED departments in these 3 hospitals. Now, of those attendances, a small number, 700, were individual people with BPD-related ED presentations in that single year, only 700. Okay, so what we tried to do was to look and see if their experience in ED and the circumstances around their ED visit were different compared to people who had a depression-only diagnosis. So, because they're often presenting for similar reasons. So they were matched on age, they were matched on gender, and they were matched on primary reason for visiting the emergency department. So that's 583 cases we were able to do. So what we found was, we looked at sort of the background, what community mental health supports were being used by people attending the emergency department with either a borderline personality disorder or a depression diagnosis. The ones highlighted in red show where it's disproportionately one or the other. So people with borderline personality disorder diagnosis were very likely almost 1/3 to be being seen by a psychiatrist, to be case managed. And for people who aren't familiar with case management, this is reserved, it's offered by public mental health. It's reserved for people who have complex long-term needs that often require a team of specialists to care for them. So it's case manager is someone who coordinates the care that an individual receives. And you can see that the proportion being case managed who have borderline personality disorder is substantially larger than the proportion of depression cases in our study. By contrast, people with depression only coming in for same reasons, suicidality, self-harming behaviours and overdose, most of them were managed in the community by general practitioners. When you look at co-occurring diagnoses, so once again, we've got our people with BPD diagnosis in the central column compared with our people who are matched on sex, age and the reason for coming to ED, but with a diagnosis of depression. You can see that substance use disorder is more common in people with BPD, as are other major mental health disorders such as schizophrenia or psychosis and bipolar disorder and eating disorder. And I've left depression sort of in a slightly different colour because you can see the majority of people with a BPD diagnosis also have depressive disorder. Now, we had a look at the Australian Institute of Health and Welfare annual report. So this report's on emergency department statistics. So we found in our study, for instance, that the proportion of men coming into our EDs with a diagnosis of borderline personality disorder was much lower. So that's sort of a bit of a flip side way of saying that they're mostly women. In terms of the age, people in that sort of 15 to 34 year age range only represented a bit over a quarter of all mental health, of all emergency department admissions across Australia in that year, whereas we have younger people being the majority there. So it's getting on to 2/3. Arrival by ambulance was high, especially for people with borderline personality disorder, which ties in neatly to the earlier study. And both people with depression and BPD, only about a third, a bit over a third, were treated within the recommended time frame. That depends on the triage category. In terms of frequency of ED attendance during the 6 years that we had records, so we see that people with borderline personality disorder who came in more than once during that time period, it was more than 9 out of 10. Okay, so it's slightly less than people with depression who don't have BPD. Now, however, when you go into the more the extreme numbers, so 20 to 100 times over that 6-year period, or more than 100 times, you see that although it's quite a small number of people, it's not replicated by the depression cohort, the matched depression cohort. So it's something that seems to be very much associated with the borderline personality disorder presentation. So I think pretty clear what we've seen here is that although people with borderline personality disorder attend ED a relatively small number of times, it's a very small number of people. Okay, so we see this repeat presentation. So people with borderline personality disorder are more likely to arrive by ambulance, have comorbid psychiatric disorders, be under the care of a psychiatrist and case managed, which also speaks to the severity of their presentation. However, and we see that they come a lot more frequently than people with a depression diagnosis. So I think what we're seeing here is that repeated ED attendance of people with BPD is highlighting the severity. Okay, so it's not everyone with BPD, it is a severely affected subpopulation, but also suggests that there's some inadequacy of community mental health services for meeting their complex needs, which sort of compels them to repeat that cycle. The third study we conducted was a coronial study, and we did this in collaboration with the Victorian Coroner's Court. And chronic suicidality is indeed a hallmark feature of borderline personality disorder, and it's sometimes referred to or reflected on as being a coping strategy in some ways. So it doesn't mean that people are committing suicide or attempting suicide. Often it's just the thought that it is available if things become too overwhelming. What confuses this, though, is death by misadventure, because, of course, self-harming can be quite dangerous, quite high lethality, and sometimes death may be accidental. And it is kind of a bit uncertain sometimes whether there was suicidal intent or not. So a frequent finding in coronial inquests is that despite frequent contact with mental health services, the BPD appropriate treatment is often not offered or available. Now, that's our observation. It's not actually pointed out as a shortcoming in the coronial recommendations, because often people are being seen by mental health specialists, they are receiving medications, they're being diagnosed, they're being referred, and still they're end their lives in suicide. So our argument is that there's not enough BPD appropriate treatment being offered to people whose lives end like this. So we utilise the Victorian Suicide Register, which is similar to the ambulance register. It's a coded database for which you can put in keywords and you can pull out relevant cases, and it's extraordinarily useful for doing this kind of epidemiological research. So if we look at suicides in Victoria during this 5-year period, just highlight the bottom right corner, we're talking about 2,870 deaths by suicide. Now, if you look across to the diagnoses, so these are all pre-morbid diagnoses, so we weren't diagnosing looking back on people's cases, it was all diagnoses made prior to death. You see 12% of people whose lives ended by suicide in those 5 years had borderline personality disorder, and 72 people were suspected of having borderline personality disorder, but it was not diagnosed. So we did not use those people in a subsequent study. And then if you look at other personality disorder, 14 had been diagnosed with either antisocial or narcissistic personality disorder. And you see other mental health disorders, so the vast proportion had been diagnosed with something, but there are also quite a large number of who'd been suspected but not diagnosed. And what's quite concerning is that 25% of cases here had no mental health disorder diagnosed prior to death. Now, in terms of looking at comorbidity, so similar to our earlier study. We have the no BPD group here in the middle column. You can see that's the vast majority of cases. And then we have the BPD group. So that's the ones BPD was definitively diagnosed for prior to death by suicide. So you can see everything's in red, and that is because people with borderline personality disorder had a high proportion of them had these co-occurring diagnoses. So it speaks to perhaps their severity, but perhaps also different diagnoses given during their treatment journey through the mental health system. Similar to the ambulance and the ED study, we see that people who die by suicide with a diagnosis of BPD are disproportionately younger people. Okay, you can see that early peak in the red part of the graph, whereas for people who die by suicide but don't have BPD, you can see it's more spread across with a peak around late 50s, mid to late 50s. And then don't be overwhelmed. What this is showing is a very important message. It's people are seeking treatment, they're seeking care, they're seeking support, they are looking for services. So in the middle column is people who don't have the BPD diagnosis, and the right column is people who do. And what we see is that contact with services, providers, within 6 weeks of death by suicide. Over here at the right side, I hope you can see my cursor, 87.8% of those 181 people were seeking services and support within 6 weeks of their death. And this is almost double people who don't have BPD. If you go down that right column, you can see a lot of them were receiving care from a psychiatrist at the time, more than half, 20% from a psychologist, nearly 50% from some mental health practitioner. The arrow here is to show 25% had actually attended an emergency department within 6 weeks of dying. Okay, and you can see the heads of inpatient and community. So people are seeking treatment. So what this is telling, and just a comment at the bottom, if we look at the 12 months prior to death by suicide, that number goes up to 99% of people who are presenting at services looking for treatment. So the cycle is really quite clear. I think what I want to focus on with these data, because they are quite overwhelming and quite distressing, is that crisis-driven mental health services are not the solution. You know, Lois has talked about lots of different treatment options. Giles beautifully described, you know, whether we should compel people to be treated or not. And some of the people to whom compulsive treatment is actually required are people who come to emergency departments frequently in high degrees of stress. So one thing that's important, I remember hearing Sathya talking about how many people in Victoria have BPD. And on a population basis, where say we think about 1% of the population may have BPD in their lifetime, at the low end, it adds up to about 30,000 people. So you can see the numbers we're talking about here. We're nowhere near those large sizes. The ambulance data and the coroner's data, they're both statewide data. So what we're talking about is people in this cycle of repeat crisis-driven presentations are the most severely unwell. So they don't represent the borderline community population as a whole. They represent people who are really in need of help and at quite considerable risk. So the costs associated with these repeat emergency crisis presentations are disproportionate to the number of people seeking BPD appropriate treatment. And it would make a lot of sense to actually cost this and compare it with the costs of proper evidence-based treatment. So we know that BPD is a serious mental health disorder, and we also know that the average life expectancy is 20 years lower than for the general population. So there's a range of evidence-based psychotherapeutic treatments. Lois was talking about some of those. However, in our under-resourced mental health system, availability and access are still key problems. So what can we do rather than feel frustrated and helpless and just upset with the situation that we have to put up with? I've tried to boil it down to a few things, some of which we're already doing, some of which are done in isolated places around Australia and other parts of the world as well. So what we really need is a comprehensive approach that would incorporate
three things. The first is training. So I think it's pretty clear we need to broaden paramedic training to include mental health specific content. We also need to train our ED staff, because often the ED visit is a traumatic experience in its own right, both for staff and for consumers and for their carers. We're doing this at the moment in our Eastern Health emergency departments, putting out a training and intervention program to promote understanding, empathy, confidence and competence in the care of people who experience those distressing ED admissions. Also including BPD appropriate, ideally, psychotherapy as a core component of psychiatry training. I think psychotherapy is more of an optional thing at the moment rather than as a central part of training. And given how many people are under the care of a psychiatrist in the coronial study, I think this is really pertinent. But also to add accurate and comprehensive content about personality disorder to all allied mental health curricula. And to do this, we'll need to engage with the peak professional organisations to make that, for them to put that in as a compulsory requirement. The second thing is to have more cooperation across our services and professions. So there's some very good studies. One's a New Zealand study, one's a UK study, and we have done one in Geelong as well here in Victoria, which I don't think is published, looking at co-response teams. So this is when there is an ambulance call out that is related to a mental health presentation, a mental health staff member attends with the paramedics, and a lot of very good outcomes associated with that, including fewer call outs in the future for people who tend to call frequently, and less people transported to the emergency department and becoming inpatients. So just having someone who understands and can perhaps de-escalate, provide the needed psychosocial support at the scene seems to make a big difference. Also embedding mental health professionals who have specialist personality disorder training within public mental health services. And an example of that is a huge program that has been running for the last 4 years in Victoria called the Personality Disorder Initiative, which was designed to set up mini spectrums in area mental health services so that there would be more self-sufficiency and people could get treated in their own communities more comprehensively and with greater understanding. And also having clear and reliable referral pathways. And I think this is the key where we can have people referred in a reliable way. And final one is increasing the availability and access to effective and appropriate treatment. And this is things that are very specific to people having just experienced a BPD-associated crisis. So ways are listed here after our alternatives to the ED, because often there's nothing else available when people experience a crisis. A post-ED referral through HOPE in Victoria has been set up in the last few years, which helps address suicidality. Bryn Grenier, pictured in the bottom here, Project Air with his team, and the Gold Card clinics, which was referred to briefly by Lois actually, which gives a place to refer from ED for people with borderline personality disorder, just to break the cycle, to provide psychoeducation and better supports. And also increasing the number of sessions that psychologists can offer. At the moment it's 10. We have fairly good evidence that 20 is better for many people. And then national training programs for clinicians and making treatment and training for clinicians to help people with BPD simpler and cheaper. I think my time's probably up, so just want to say thank you very much to colleagues on these 3 papers. You can see them listed here, different organisations as well as some individuals who helped with the ED audit that we did. And these are the 3 studies if anyone is interested upon which these data are based. Thank you very much for your attention.
Thank you, Gillian. I think you clearly highlighted a very important challenge that we have while working with people with borderline personality disorder in the healthcare systems. We have unfortunately run out of time for question and answers. If I could invite you to make comments online. And so thank you again. Let's break for lunch now. And if I could invite all of us to come back by 1 o'clock, 1 p.m. Melbourne time. Thank you.